Okay, so I would like to start by presenting our first presenter. We have here Dr. Batool. So let me first share her presentation and then so we can start immediately. So we have Dr. Batool. Dr. Batool Hashmi. She's an emergency medicine resident at Sheikh Khalifa Medical City in Abu Dhabi. She's actually a senior resident. So welcome, Dr. Batool, and thank you for accepting. Thank you for presenting today.
Hi, everyone. Good afternoon. Thank you for giving me the opportunity to present in renal tox clinical rounds. Shall we start?
Yes.
Okay, I don't see the presenter view. It's in the normal view.
You cannot see my screen?
Okay, it's shown. Never mind. Okay. So I'm gonna start with my case today.
Sorry, 1 second. I'm just going to 1 second. Stop the sharing. Yes. 1 second. Can you see my screen? No,
Yeah,
can you see?
we can see it, but it's not on. Yeah, now it's a good.
Okay, good.
Okay. So I'm going to talk about a case that I encountered in our emergency department in SKMC. So this is a mother who was 31 years old, female, previously healthy, came in with her daughter who is a 2-year-old female, who's also previously healthy. Starting with the vitals, both of them came into the emergency asymptomatic, and both were vitally stable, and their physical examination were unremarkable. Next. For the history presenting illness, the mother was brought by the police along with her daughter with a history of possible toxic ingestion and overdose. The mother had ingested multiple pills that belonged to the infant grandmother. She did so in the intention of ending her life, then gave some pills to her daughter as well, and this is also known as extended suicide. After that, the mother went to sleep, leaving her 2-year-old child unattended. So the focus of my presentation is going to be mostly about the infant, and starting with the initial VBG. It was remarkable for a low glucose level of 1.3 and hypokalemia with a level of 3.1. So I want your input. What's your impression and what investigations would you do?
You can utilize the question and answer. And whoever would like, to share their thought, I can just unmute you. Oh, we have here someone's raising his hand. So, of course, okay, Yusra. Hello, hi Yusra. Do you have a question? Okay. I think it's maybe by mistake. Okay. So let's see the question and answer. Good. So we have ECG. Someone is asking for ECG. Can VBG again? Good. So you want to go for the VBG again? Sure. Okay. So let's go to the VBG again. So this is the VBG. So we have here can we see the VG again? Do you have renal function? Someone asking about renal function, ECG, hepatic function. With hypoglycemia, I will think about beta blocker. Good. Did the grandparent has diabetes? Anti-diabetic medication were around. Good. The absence of the initial symptom does not mean safety. Good. I like this. As some medication may cause late symptoms that require constant monitoring. Yes, I agree with you. And the oral hypoglycemia injection, good. Okay, so
Okay. So we took further history from the mother.
good. Okay, so let's go next.
Yeah. So we took further history from the mother, and she mentioned that she ingested the agent glimepiride 4 milligram and gave her daughter the same agent. She was not sure of the quantity of the pills her daughter ingested, and whenever someone new entered the room taking history, the mother would change her narrative of the story. So she gave us another narrative where the mother, while waking up, she found a couple of pills missing. Next, please. And the mother eventually admitted that she wanted to end her life and her daughter's life because she claims that her infant was sexually assaulted by the neighbor, and she tried to complain to the police, but no one believed her or listened to her. In the ED resuscitation room, as you all saw in the VBG, her initial glucose was 1.3. She was given apple juice, chocolate orally, and a bolus of D10, 2 milliliter per kg. The second blood glucose, she had improved, and she was also started on a maintenance rate and with KCL infusion. But then 2 hours later, after presentation, a repeat glucose was done, and it also showed low level of a 2.5. And she was given another bolus of 100 ml of D10. PICU were consulted for admission as a case of intentional glimepiride intoxication leading to refractory hypoglycemia. We did for her further labs. ECG was a good answer, but unfortunately, in an infant, it can be really difficult as she was really active and alert, and it was not feasible. And we did for her like general labs like CBC and general chemistry, and also urine tox and acetaminophen level, salicylate level to look for or search for co-ingestion, and all of them were negative, and the labs were only significant for the periodic blood hypoglycemia and hypokalemia. And for the hospital course of this infant, she was admitted in the PICU.
Batul, I'm gonna just like pause you here for a while.
Yeah.
I'm just going to go. One of our attendees are asking, do
Mm.
you receive activated charcoal?
No, because the time of ingestion was unknown, as I mentioned in the history of presenting illness. The mother was unclear on the timing and whether the baby had actually ingested the said amount of the medication or not. So it was unknown when the infant took these medications.
Okay, great. But actually, like up to 2 hours, 3 hours, even for me, up to 4 hours, because this is the antidiabetic, like the sulfonylurea group. Usually, they are all long acting, so you can
Yeah.
consider charcoal.
Yeah.
Yeah, especially if the child is like cooperative and willing to drink,
Yeah.
I would like to ask, Dr. Samia, to give us her thought about this case at this point.
Thank you, Afra. Am I audible?
Yes.
Yeah.
Yeah, I have some issues here. Thank you, Dr. Afra. Thank you, Dr. Batool, for this Nice presentation. Actually, this is a very important cases that showing us, I mean, the importance of insidious symptomatology for sulfonylurea. I wanted to highlight some differentials that we should think before the diagnosis is about. We can also consider the ethanol, and for some, I mean, cultural or some like families, they can have like child neglect and they have access to children. A small amount can cause the hypoglycemia. As Dr. Afra said, the beta blockers as well. We can consider other non-tox differential diagnosis as well. There is some rare conditions like the insulin secreting tumor, but it's very rare in 2 years old. And we can like considering that beta blocker also toxicity. And the most point that we have with sulfonylurea is the risk. It's one pill can kill. One pill can cause the hypoglycemia in children less than 4 years old. It depends on the weight actually. That's why this is for such cases. It's very easy to misdiagnose these cases. So if they share with us the time of exposure, surely it will be like a little bit long because symptoms take time to, or the onset of symptoms is a little bit long. At this point, for this patient, what I can consider is the reliable history. This is very, very important for us because the mother story kept changing. This is a classic feature in many tox cases, especially those involving self-harm or harm to others. This is so the principle here, when faced with conflicting history, we must always assume the worst case scenario and trust only our objective findings. Initial blood glucose at 3 was like the single most important piece of data here in the room, and the objective is to manage this patient. Regarding the bolus, I mean, of dextrose, simply it's dangerous. Why? Afra, can I give information regarding the antidote at this point, or we wait for
I'm going to
slides?
talk about it further in this presentation.
Yeah. You mentioned maybe the bolus of glucose.
Yeah,
Briefly, yes.
So I can't ask the audience, what do you think? Is it safe to give the dextrose? What do you think? You can answer us in the questions in Q&A or the chat.
Okay,
What
so
do
we
you think
have
about the bolus of dextrose? Is it good to give it? What do you think?
so we have here some of they are asking about glucagon. Would we consider glucagon in this case? Dr. Samia, and then we have here another comment about okay, so let's talk about the glucagon. What do you think about the glucagon, Samia? Hello? Samia, could you hear me? Okay, so basically glucagon is not part of the treatment for sulfonylurea toxicity. Usually we will give dextrose. However, patient is awake, able to eat, then you will give them, I mean, food to eat. Usually what we will tend to give is to put the patient like, and if they keep on dropping their blood sugar, then it is better to put them on infusion of dextrose rather than boluses. And then, of course, the close monitoring for the glucose. This is very important. And then it comes the antidote. So for me, I would think that antidote should consider if you had 2 to 3 drops, not 2, and then 2 drops and blood glucose, then this the amount of even if it was small amount, it considers still like I mean like toxic. So that's why we would consider the antidote in this case, especially in pediatric population. Keep in mind that toxicity of sulfonylurea can also happen in a chronic scenario, not only in acute setting. So in a chronic scenario, maybe with patient who did not overdose, maybe you will be more like reluctant to give octreotide or the antidote. You will wait for it. But then in other scenario, in an acute scenario, it should be like, especially if it is confirmed and there is hypoglycemia, then it's better to go and give it with the dextrose infusion. Sami, I'm not sure if you can hear us or you are
Yes,
back.
yeah, I'm back. Yeah, sorry for technical issue. So I wanted to mention about the dextrose. What will happen when we go to mechanism of action? What will happen when we give the dextrose? So this can be potentially dangerous strategy in sulfonylureas. Why? Because when we are given dextrose, we treat the number, but it also stimulates the pancreas to release even more insulin. So this is not the treatment. We create like a vicious cycle of recurrent hypoglycemia. That's why this is like the octreotide is a definitive antidote. Why? Because it acts like a chemical off switch on the pancreatic beta cells directly to stop the insulin release at its source. It's the key to like break this or breaking this cycle of the recurrent hypoglycemia. This is the risk with the dextrose, especially with the continuous one.
Excellent. Thank you for that, Samia. I'm just going to read over some of the question. There's for these kids, the ingestion is unknown, the amount of ingestion. How long should we keep the infant for observation? And what tool would we use to help to guide us for the disposition of this patient?
This is a very excellent question. Because for sulfonylurea, this is a very like important to think about this position and monitoring. So defining medically clear for these patients is so critical. Why? Because the admission is important. Why? Because we need to at least observe the patient for 24 hours after the last dose of octreotide. This is really important, because during that time the patient must tolerate like meals without any drop in glucose, because the sulfonylureas have very long action or effect. That's why we need to be sure that this patient is really medically clear from sulfonylurea. This is really important, because when we achieve the state of hyperinsulinemic euglycemia without intervention, this needs time to be like that we will be sure that we are in this state exactly.
Excellent. Thank you, Samia. So here, like someone was answering like 24 hours. The thing is that the moment that you have a patient symptomatic, it means this is a toxicity ongoing. So a patient should be admitted as long as patient symptoms improved and like she became euglycemic. And then even after euglycemic, she need to be monitored for a while. Remember that most of the sulfonylurea group, at least their like, half-life is like at least from 24 hours up to 58 hours to 60 hours even. Okay, so remember that it can last for a couple of days. And remember, this is like the half-life usually, which which are studied in a therapeutic dose. And remember, in this scenario, this is an overdose.
Also, yeah, I wanted to add something regarding the because usually always we have the question about, for example, how frequent I should monitor the glucose. For example, we need to have in mind that in the first 8 hours it's so critical. We need to check the glucose. While we are treating, we will check it minimum hourly in the first 8 hours, and then we can space out it to every 2 hours, for example, if they remain consistently euglycemic. This is really important. What we can add also is if the patient is alert, we can help to provide meals, snacks, etc. It depends on the status, clinical status, and the most important point is after in my opinion, is after all the treatment of this episode is the psychiatry referral. This is really important for this patient.
You mean for the mother?
Yeah,
Yeah,
exactly.
Because this is like, this is like a type of psychiatry illnesses when you try to harm, it's called by pyroxy. I'm not sure about that. I forgot the term. Actually, it has a term. If anyone of the audience can help us with that term.
Also we need, for example, to send the paracetamol level, as we are suspecting maybe she took other things, so we can do the screen, the tox screen. We can send paracetamol, salicylate, basic metabolic panel. This is can be done for such cases. This is important also to do the ECG to check for any co-adjustant.
Okay, so just thank you, Sami, for excellent input. I'm just going to go through the chat, the question and answer, because we have so many, comment here. So we have here somebody asking about glucagon. As we told you, that glucagon has no role here. It's mainly like you can give patient like food and dextrose. Of course, they're acutely hypoglycemic, but then the antidote is octreotide for those who are asking about the antidote. Okay, so then we have here a large IV dextrose bolus cause a rapid glucose raise, trigger massive insulin release, the drug's mechanism, and lead to rebound and prolonged hyperglycemia. Yes, I agree with you. However, if patient is hypoglycemic, it's just a bridging. It's okay to give dextrose for till you get the antidote, you know?
Exactly, Afra. Yeah, I agree. Afra, I wanted to just add something regarding glucagon. Glucagon, because we are still having questions. So glucagon in the mechanism of action directly, it will work primarily to stimulate the liver to break down the glycogen stores. This is mainly to release the glucose. This is the mechanism of action. But for us here, the underlying problem is that sulfonylurea's poisoning cause the profound hyperinsulinemia. So the pancreas is being stimulating the release of massive amount of insulin. So when you give glucagon, this does absolutely nothing to stop the insulin release.
Okay, great. Thank you so much, Samia. We have here a question about how to provide the psychological support for mother after a medical condition is stabilized. So basically, this is what we did. Maybe, Batool, she can tell us more about what they did in this case, but while we proceed in the case itself. Okay, so here we have another. When would you give bolus? So what I understand is you can give bolus, but a similar amount that what is normally recommended. As I'm thinking of my patient has RBG and 1, okay, so blood glucose of 1 and with low GCS. So my dear, you can give boluses. However, you can give boluses, but you can give bolus, of course, because you want to increase the blood glucose level, because actually hypoglycemia by itself, it can result in so many other complications when it comes to sulfonylurea. So it can cause arrhythmia, cardiac arrhythmia, and then CNS manifestation, which can end up to severe hypoxia, seizure, severe brain damage, all of that, which it's happened, but rarely, but it can happen with untreated cases. We have also because mashallah, we have so much comment, so much, things people are writing. What if the patient goes to hypoglycemia again, as sulfonylurea are no longer acting? We'll talk about it because basically octreotide is the treatment. Did the infusion cause more stimulation of insulin and aggressive hypoglycemia? Is it better to bolus infuse? Okay, we already, I think, answered this. Okay, good. We have the Munchausen syndrome by pyroxy. Thank you, the anonymous person. Yes, this is basically, I think, what the mother has. What is the Reem window of administration octreotide? So basically, if the patient is hypoglycemic, you go ahead and give, the octreotide, and you have already the history of overdose with sulfonylurea group, you know. It is okay. Home call and neither come to know. After some, we can give recommendation to take taking orally till reach hospital. I'm sorry, I didn't get the question. But yeah, I think if you mean that if the patient already hypoglycemic and they're at home, especially if they are awake, because as you can notice in our case, the child was playful, active, but she was hypoglycemic. So yes, definitely that you can ask them to have juice, to have like honey, something that will get absorbed fast. Okay, so what about potassium monitor and how much frequent we should check? Okay, I will let now Batool proceed with that, and then she will talk also about the potassium in this case. Okay, Dr. Yes.
Yeah. Okay, so for the hospital course of the patient, she was admitted in the PICU as a case of extended suicide by glymphatic toxicity leading to refractory hypoglycemia. The patient received another bolus of D10, 100 ml in the PICU, and UOH docs were consulted, and they recommended an initial dose, 2 doses of octreotide, 20 mics sub-Q every 6 hours with periodic blood glucose monitoring. Initially, the monitoring happened like every 30 minutes initially, and then after the stabilization of the blood glucose, they would monitor the blood glucose every 4 to 6 hours. And how we handled this case socially, social services were alerted on the case from the beginning in the emergency department. And as soon as we knew that it was a case of extended suicide, the mother was separated from the child immediately, and she was admitted under IM, also as a case of glimepiride toxicity. And of course, she was also followed up with psychiatry. So talking about sulfonylureas, glimepiride is considered a second-generation sulfonylurea agent. I will touch on the mechanism of action shortly, but the general picture is that it stimulates insulin from the pancreatic beta cells. Its peak effect in plasma is in 2 to 3 hours from initial acute ingestion, and the duration for glimepiride specifically is 24 hours, and it's metabolized by the liver, and mostly its excretion is through the urine. So coming to the mechanism of action, so basically what happens in pancreatic beta cells, in a normal person, glucose enters the cell, and then glucose is converted into ATP. And then we have a channel, the potassium ATP channel. When there is an abundance of ATP intracellularly, the channel closes off and not letting the potassium get out of the pancreatic beta cells. And this creates a depolarization of the cell membrane. And further depolarization of the cell membrane will cause the calcium voltage dependent channel to open, and this will allow an influx of calcium into the cell. And further phosphorylation reactions will cause insulin exocytosis from the pancreatic beta cells. And for sulfonylureas, how they act exactly on the potassium ATP channel.
Excellent. So do you want to explain also the octreotide on this or on the second?
Yeah, on the second slide. And so why we mentioned that the boluses of glucose might be harmful actually to the patient, because it will create more risk for the patient that they would have recurrent or refractory hypoglycemia, just from the mechanism that I just explained. And we need an antidote for sulfonylurea, which is the octreotide. And octreotide, basically, as you all mentioned in the comments, most of you, it's a somatostatin analog, and it acts specifically on the voltage-gated calcium channel that is on the cell membrane. And basically, it blocks this channel and prevents the influx of the calcium intracellularly, and that's what prevents the insulin to be secreted from the beta pancreatic cells. And so we have prevented the hyperinsulin status of the patient and the recurrent hypoglycemia state.
Excellent, Batool. I'll just add, like here, if you can see that actually the octreotide will act on the octreotide will act on the calcium channel. Basically, it will block the influx of calcium. So, so by blocking that channel, it will not. It will inhibit the cyclic part of it. Will inhibit cyclic AMP, and it will also inhibit. The insulin release from the beta cell. Okay, so we can. Do you want to add anything, Batool?
No, that's it.
Okay, so well, next.
Okay, so from what Dr. Afra and Dr. Sami just mentioned, activated charcoal, it can be given to a cooperative patient and patients who present from 2 to 4 hours of acute ingestion. And also, it's very important the maintenance of the hypoglycemic state, um, preferably with the maintenance fluid. And then the antidote, which is the somatostatin analog octreotide, the recommended dose for children is 2 mics per kg with a max dose of 50 mics. And it has to be given either IM or sub-Q every 6 hours. And for adults, the dose is 50 to 100 mics, sub-Q or IM, and also for Q 6 hours. And octreotide is recommended that it be administered in the first 24 hours. And then after discontinuation of octreotide, patients should still be under monitoring for glucose for another 24 hours.
Excellent, Batool.
Thank you so much.
Thank you for this great presentation and great cases. Before we go to our next case, I mean, Sami, if you would like to add anything, please let me know so we can like maybe have 1 minute before we go to our next case.
Yeah, I wanted to add some small points regarding the how to give. We can give the octreotide IV. We can also, for some cases, repeat the dose 4 hours because it's mainly typically 6 hours, every 6 hours, but sometimes we can do it at 4 hours, depending on the symptomatology. Also, if you do it with IV, we can dilute it in 50 ml normal saline or 5% dextrose, and then we have 2 options to do the IV push over 3 minutes, or we can infuse it over 15 to 30 minutes. This is if I give it the IV. This is mainly what we have. The contraindication for octreotide is only if we have the the allergy or hypersensitivity or to directly to the octreotide. Other than that, we can use it normally. This is as you said, it's used in combination with the IV dextrose, the boluses in the beginning, because we cannot like keep the hypoglycemia just because we will be worried from the insulin stimulation. So we do both in treating the patients initially. And we should monitor for the recurrent hypoglycemia. It's really, really important. The one thing I wanted to highlight here for this cases, 2 cases, this proves something very important, which is the vulnerability or a risk, the high risk for children regarding the 1 pill can kill. As you see, different symptomatology for both of them, directly related to the dose per weight. This is mainly what I can share for this. Thank you.
Great discussion. Just before we proceed, I forgot actually to announce that today webinar is a CME accredited. So inshallah, everyone who's joining today, we will like shortly, within inshallah 1 week, we'll send you your CME certificate. So I would like to start introducing our next presenter. Our next presenter is Dr. Reem Khalid. Dr. Reem Khalid, she is emergency medicine specialist, Jordanian board certified. She did her medical school at Sudan, and she did her internship and residency training in Dubai Health. Welcome, Dr. Reem, and thank you so much for preparing this presentation. God know that actually our first or initial presenter dropped out in the last minute, unfortunately, and Dr. Reem, she really helped us to have today webinar, because she came up and she was able to do this presentation within only 2 days. Highly appreciated, Dr. Reem.
Assalamu alaikum. Thank you, Dr. Afra. It's always a pleasure, and thank you for the opportunity.
Sure. Whenever you are ready, we're ready.
All right, we're ready.
Yes.
So today's topic is going to be the same trigger, 2 different journeys. So we have 2 patients, patient 1 and patient 2. Patient 1 is a 56-year-old male who presented to the emergency with a complaint of left ring finger pain after being stung by an animal. And patient 2 is a 38-year-old male who presented to the emergency department with a complaint of left great toe pain after being stung by an animal. So disclaimer that those two patients presented on separate occasions and not together. Examination-wise, patient 1, vitals, heart rate was 92, BP was 156/86, afebrile, respiratory rate was 18, and SpO2 was 100% on room air. Patient 2's vitals, heart rate was 74, blood pressure was 130/70, afebrile, 19 breaths per minute with an SpO2 of 100% on room air. So patient 1 was conscious, alert, and oriented fully. GCS was 15/15. He had swelling, erythema, and tenderness on the left ring finger. Otherwise, the remainder of the examination was unremarkable. Patient 2 was conscious, alert, and fully oriented with a GCS of 15/15. The left great toe was swollen and dusky as the patient had a tourniquet in situ. So after removal of the tourniquet, the color gradually returned to the toe and he had intact sensation and capillary refill. There were some sting marks noted on the great toe. Otherwise, the remainder of the examination was unremarkable. So what are your differentials and what would you consider next?
Share your thought. What is your differential? Good. We have someone who's saying scorpion bite, spider bite, check coagulation profile. Okay, all good approach. So, and differential diagnosis. Good. So land animals, snakes versus scorpion. Good. Scorpion sting, snake bite, spider or snake. Good. ECG as well. Okay, so someone's considering ECG as well. Snake bite. Okay. Good differential, but let's talk about non-tox. If this was non-tox, of course, the tourniquet, I think it's gave it away because there's a tourniquet. Maybe scorpion and observation for 6 hours. Okay, that's good. So what to consider next? I noticed that the only someone to asked for coagulation and then ECG. What else would you like to do? Okay. Someone's asking about augmentin, antibiotic. Okay, this is good. I like that people are thinking about these things because we need to, address all of these. Tetanus vaccine as well. Wound management. So here we have the difference in symptoms progression between the two patients may help determine the type of toxic agent and how long it will last. Okay, good. But just remember, in these two cases, they are not, they didn't come together. There are two different patients. I think you saw them, Dr. Reem, on the same day, right?
No, it was about a couple of days apart.
Okay, good. Okay, the difference in symptoms progression between the two patients may help determine the type of toxic agent and how long it will last. Excellent. And that's why actually, although they are not together, but we presented them together because I'm sure you know that they have the similar exposure. That's why I want to discuss that. Okay, so symptomatic treatment, good. 20 minutes of white. Okay, so this is basically to check for coagulation. We have here tetanus vaccine, setting of bite and fang marks if there's any setting. Okay, good. So do you want to proceed? Let's proceed and then.
Sure, doctor. So patient 1 had described what he was bitten by, and he described a black scorpion. Patient 2, this is an actual picture of the scorpion that was taken by patient 2. And as you can see, it's this, beautiful blue-colored scorpion. So we'll just move to the next slide. All right. So lab-wise for patient 1, as you can see, patient 1, the only remarkable thing in his labs were that his WBC count was at 15.9 with neutrophilia. He did, however, coincidentally have a raised troponin level, but 2 sets were repeated for the patient with no increase in them, and he had a negative CKMB. Patient 2 remained to have normal labs throughout.
Okay, so do you want us to pause just here? I
Yes.
just want, like in this case, if you know, or if the patient reported a scorpion bite, what investigation overall would you consider? And would investigation or lab result has significant changes, I mean, in this type of exposure? Okay, we have someone asking for ECG. Did you do ECG, Reem, for this patient?
As far as I remember, for the patient number 2, there was no ECG that was done for patient number 2, but I'll just have to double check for patient number 1.
Okay, sure. I mean, because both patient had like normal heart rate. Both of them, they were they weren't hypotensive or something, right? As well, like they had normal vital, urea and electrolyte, thrombocytopenia. Okay, so we have these. So I think we're gonna proceed, and then we'll do like full discussion about the management and what to consider. Okay, so Reem, you can proceed.
Sure. So the ED course for patient number 1. So patient number 1 was complaining of severe pain in the left index finger. So patient number 1 received a, we'll move to the next point, Dictora, if that's okay.
Sure. Okay. Yes, you can. Okay.
Does anyone have any input regarding digital block and its aid for such bite in terms of like pain management? So there's one of the questions that was asking from which country is the scorpion from. So this happened here in the UAE.
Yes, UAE in Dubai actually, right, Reem?
Yes, that's correct.
Yes, both cases in Dubai. Okay, so someone's asking about local lidocaine. Good. So basically, digital block is very known as part of the pain management treatment and scorpion bites. So yes, I just want, I mean, to pause here. With patients with severe pain in the left index that require digital block, would anyone of you here consider to give the antivenom? Okay, we have one answer is no. I hope this is that you're answering my question. Okay, yes, if that's severe. Okay, someone's saying yes if that's severe. Okay, ask them near marines if they were like.
Dr. Afra, let me ask a question also. Are the scorpions here in the UAE region causing coagulopathy or cardiotoxicity?
Okay, so I think till they answer the question, which is a very great question. Not without systematic symptoms, and pain improve with what? Okay, pain improve with digital block. Good. A digital block will not increase risk of compartment syndrome of digit. No, it will not. If this is what you are worried about. Okay, yes, if pain not responding to analgesia, but remember we'll do digital block, and this is what this patient received, a digital block. So usually digital block is very, very relieving. No indication now. Good. We have cardiotoxicity. Someone is asking about cardiotoxicity and coagulation problem. Okay, then we have mainly cardiotoxicity and neuropathy. Good. Cardiotoxicity and neuropathy. This is excellent. Okay. Of course, Dr. Badriya, I'm sure, and Dr. Badriya, she can, I mean, teach us an actually scorpion bite. Cardiotoxicity common. Is there a specific classification available to indicate antivenom? Good, actually there is, but it is based on United States and Canada, and you can find it actually in Gold Frank. in the chapter Anthrax, where actually there's a table of 4 category for depending on grade and symptoms, basically grade 1 up to grade 4. And usually for grade 3 and grade 4 is actually the indication for antivenom. Good. Someone is asking about troponin, antivenom, if okay, symptom information. Okay. So Samia, you can maybe answer the question that you asked.
Yes. Yeah, mainly the scorpion here in our region, they cause mainly, as Dr. Badria said, the cardiotoxicity mainly and neuropathy, but not coagulopathy. That's why sending like the labs for coagulation profile initially is no sense for such exposures because it's not snake bites. Other thing that we can say about the ECG, it's really important to do it because of the risk of cardiotoxicity, even if we have the vitals within normal range. Troponin can be considered as well. It showed it's very good marker that showed like the correlation with the severity. It will be changed and higher, like it will indicate for us, early the envenomation. It's a good marker. Other thing we can, it's mainly to watch for the symptoms, as you said, Dr. Afra, there is the 4 grades for this for this symptomatology for scorpion stings. And from that, we can find if there is envenomation or no. This is our indication for the antivenom. If we confirm the envenomation, we should give. Why we are saying envenomation? Because even if it's venomous spider, maybe it's a dry sting. Maybe there was no injection of the venom. This is the point. And this is like considering that also there is many like sorry, not spider, I'm speaking about scorpion. There is like other scorpions that are not venomous at all. So this is the point.
Excellent, Samia. So I just want to just add one point that please don't get confused about, the toxicity that happen with the snakes and the scorpions. There are 2 different toxicities. So basically in the snakes, you can have either cytotoxicity or neurotoxicity or hematotoxicity, or it can be also cardiotoxicity. Basically, this is the main component of like snake envenomation. When it comes to the scorpion, it can be cardiotoxicity, but remember cardiotoxicity and can be severe neurotoxicity. And usually what kills, both can kill to be honest, but remember that both these symptoms will happen usually within the first hours. It never happened delayed, not like the snakes. So patient will develop symptoms if the toxicity was significant or the venom was significant load. And this was a venomous scorpion. Then patient will develop symptoms from the beginning, and it can progress.
Great, Dr. Afra. Let's ask the audience to share with us what they think about the observation period of
No, I need to proceed with the case because we are running
just
out.
you can answer while they continue with the case.
We can maybe go back to it. And Dr. Abedre is doing great job actually answering most of the question that we cannot answer. So we can at least allow Reem to finish her presentation. Yes, Reem, we can proceed.
Thank you for the great discussion. So the patient received IMTT, IV antibiotics, IV hydrocortisone, and IM chlorpheniramine. So there was also another point about is IV hydrocortisone and or IM chlorpheniramine, is it actually warranted or not? Does it have any role or not? So that's also another question that was risen. Sorry, Dr. Afra.
We will open the discussion about this at the end.
Sure.
Just to make sure that we delivered the entire,
presentation. Sure.
And then we're going to talk. Yes.
All right. So the patient was observed in the emergency for 6 hours. The patient was discharged 6 hours later, did not have any swelling on his finger. There was no erythema, no pain, and he was discharged in a stable ambulatory condition. Now, the interesting turn of events come for the patient number 2. So patient number 2, when he was in the emergency, he suddenly started to develop profuse sweating. He was complaining of abdominal pain and he became hypertensive. His blood pressure was 87/54 millimeters of mercury. The patient was shifted to the resuscitation room. He was started on IV fluids. He received IMTT, analgesics. He received antibiotics as well. So for patient number 2, he was actually started on scorpion antivenom. He received a total of 5 vials, and when the patient was reassessed, he gradually started to improve in terms of symptoms, as well as his blood pressure started to pick up. He was admitted to the hospital for 48 hours, and he was discharged in a stable ambulatory condition. So just a quick discussion about scorpion bites. So basically, so the Androctonus, the Nereus, and the sorry if I'm not pronouncing it correct, but the Mesobuthus species. So these are the common ones to the Middle East. So these are the main ones that we do find in our region. So in the next slide, we have images of the scorpions. So you have the Arabian fat-tailed scorpion, which is the Androctonus species, and this was actually the one that had bitten both patients. So regarding the second scorpion, which was the blue scorpion. So to be honest, it was my first time encountering such a different colored scorpion. So we had to run the image through AI to try and get the species, and it came back to the Androctonus species. We have the Arabian thick-tailed as well, and we also have the death stalker scorpions as well.
I just want to add one comment here, because we will have more discussion when it comes to that management. Usually the blue scorpions is not a native scorpion. So I'm not sure if this was a reflex because of flash or something while taking the picture of that was a real a blue scorpion. Just to keep in mind, and just this general information, in the Arabian Peninsula, we have actually 14 species or subspecies of scorpions. And almost from these 14 species, we have 7 species in United Arab Emirates. And blue scorpion is not one of them. However, remember that we are, here in UAE, we are multinationality. We have, we consider the hub of the world. So could it be this introduced to UAE, brought from somewhere? Could it be? I'm not sure. I'm just saying that this could be a possibilities. But this could be a possibility, which means this is not, what to say, it's not like a native scorpion. Just to keep in mind, or it could be just, a flash and then it gave that color, the beautiful blue color. I'm not sure if this is possible. Sure, maybe Dr. Badriya can, give us a hint, because basically UAE and Oman, they have a lot of similarities when it comes to the environment and when it comes to, envenomation, either snakes or scorpions or spiders. Okay, we can go next now.
Sure, doctor.
Yes, we can go next.
So regarding the Androctonus species, so the severity of the envenomation, so it varies from mild, moderate, and severe. So you'll find that our patient was having symptoms that are in between moderate and severe envenomation, and hence the decision was taken to give the patient anti-venom. So in the next slide is actually the anti-venom that anti-scorpion premium is the one that we have in our facility. And even on the leaflet on the right-hand side is the indications for administering the anti-venom.
Thank you so much.
Thank you very much. Thank you very much.
Thank you for this great presentation, great cases. I would like just here to read the comment of Dr. Lara. So Dr. Lamra, she's the toxicologist actually covering the service in Rashid Hospital. So she mentioned this scorpion is a toxic in the region. I agree. Despite the blue color, it considered same species of Androctonus, while if it was in Asia, is a non-toxic and different species. Good. Before we, I'm just because we have already 1 minute, but I think we can extend it to 5 minutes for discussion. Would like just to give a few points regarding the management of the scorpion bite. So Samia, would you like to start?
Yes, I wanted to mention something really important regarding the management for these cases. Mainly the difference that it's great to have these two cases because you gave us the difference between the grade 1 and maybe the grade 3 or 4 for the second case. It's really important to have this showcase this spectrum of severity. Regarding the infiltration with the bupivacaine is effective and directly to manage the pain directly at the source. This is really good. And as Dr. Badriya mentioned in the comments as well, going to short-acting narcotics or opioids as morphine is good also with the non-steroidal drugs, also anti-inflammatory drugs. And going to the also another point regarding corticosteroids and also the antihistamine. This is important to think that it's not it's a routine in many EDs, but it's not because the scorpion sting is doing the toxic process directly. That's why we need to treat the patient without like adding unnecessarily treatments. That's why if we have allergy from the antivenom at that time, we would be like prepared with our treatment for that, but we don't initiate this one early. Other thing is you mentioned already that regarding the onset is very rapid, so many 2 to 4 hours will be enough to rule out the envenomation. However, we should extend this if the pain is still there, I mean, not improved, but mainly 4 hours will be enough.
Sami, I just want to add one thing regarding
Yes.
when you said about the medication, exactly, I do agree with you. There is no role of corticosteroid or antihistamine or antibiotic in the setting of neither like both snake bites or the scorpion bites. So it's not recommended, not indicated at all. This is very old practice, and we should not encourage it, honestly. This is one thing. The other things I would say also the role of pre-medication, which it means that when you start giving, like cortisone or antihistamine, when it comes to before giving the antivenom, this has no role as well. It will not prevent anaphylactoid reaction if it will happen. So you can prepare these medication, keep them on a side, but never pre-medicate. It's not indicated. It has no evidence-based, to say that pre-medication will prevent anaphylactoid reaction. The other thing someone asked, someone like commented about the tourniquet. Yes, I agree 100%. Tourniquet has no rule as well. Well, the only things you can do, you can apply compression, like soft compression, to help the swelling, but there's no rule in tourniquet, and it will not prevent toxicity, as people used to assume. It actually can worsen things because when you are applying tourniquet, you are decreasing the return of the blood supply where actually the venom happen, and releasing it will cause like quick spread of the venom, and this can lead actually by itself to anaphylactoid reaction or anaphylactic reaction because of the venom. So that's why tourniquet is not part of it. Yes.
Yeah, I agree, Afra. I agree for that. Yeah, I can just add the small thing regarding when we treat, what we are doing exactly. When we give the antivenom, what we are doing exactly. We start from when we have the venom, what will happen. So the venom will cause the autonomic storm. So the venom neurotoxins directly cause uncontrolled release of neurotransmitters like acetylcholine, catecholamines, and we will have the hypotension and many other factors like cardiogenic shock or any other like venom-induced cardiomyopathy, massive vasodilatation or fluid loss. This is all the complications. And what we will do when we give the vials of the scorpion antivenom, this is definitive treatment. Why? Because antivenom will go directly and to bind and neutralize the circulating venom, and we will have the elimination of this inert complex of the venom, binded with or complexed with the antivenom. This is mainly the treatment how it goes, and mainly sometimes we will need to repeat the dose for the antivenom if we have very many numbers of stings or a huge amount of venom. injected. Other point I wanted to add is for some patients with, for example, GI symptoms, we should send for lipase as well. We can have it deranged. If you have respiratory symptoms, we should do the X-ray, chest X-ray, and we also should consider the tetanus vaccine as well if not given in the past 10 years or the child is not, for example, fully vaccinated. Thank you.
Excellent, Samia. Dr. Badriya has also, a comment. Dr. Badriya.
Assalamu alaikum wa rahmatullahi wa barakatuh. I just, wanted to highlight few points about scorpion envenomation, unfortunately, that we are seeing. We see a trend of more of kind of like an aggressive behavior, although we still, about probably as the being reported 76% of the cases, they go with a mild envenomation and does not require more than just a pain management and a mild supportive care. But once they, they have persistent symptoms beyond the 2 hours observation or the 4 hours observation, particularly if they have like persistent tachycardia or persistent elevation in their blood pressure, then that's an indication for early intervention. And these cases that goes into the severe form where they develop the aggressive kind of toxicity, where they have the cardiotoxicity, heart failure, or they get the kind of the catecholamine surge with all the autonomic instability. Initial aggressive management, supportive management, what we mean, along with the antivenom, is the one that is going to save them with a frequent, full recovery from their condition. So although most of the cases are benign, but this observation period is quite critical for almost all the cases. Once you see that their vital signs are not getting better, and despite the pain control, they're still tachycardic, for example, but the rest is fine, that's absolute an indication to keep a longer period of observation in a high dependency kind of setup, because when they deteriorate quite rapidly. And we have seen that, unfortunately, particularly in children, in young age, where they require kind of intensive intervention, early intubation, early aggressive inotropic support, and so on, until they fully recover later on. And I just wanted also to highlight another point when it comes to the species that we are dealing with. Yes, we have, almost the Gulf countries have similarities, but there are at least 7 main families that are highly venomous within the Gulf countries. And then these are basically the ones that have a very bad outcome. And although we are using the same antivenom, however, there are multiple factors that led to changes in the term of the type of the species or the type of the component of the venom by itself. So we see kind of like a shift a little bit away. So you might need to go a bit aggressive in terms of the antivenom, and you might need to repeat multiple doses to reach into the effect that. So you keep that in your mind when you're seeing a patient who's not responding to the first or the second dose of the antivenom. The climate change, the habits that people are tending now to have bits and so on, the migration of animals from one area to another. We are seeing currently like a little bit of a change of the usual behavior, or different type of species that were not particularly, let's say, for example, in UAE, that they are not particularly, habitat in UAE. So keep that in your mind as well when you are seeing such cases with no response to the antivenom. Maybe you are not treating the species that you think the antivenom is covering them.
Excellent input, Dr. Badriya. Before we conclude our discussion, we had today honestly 2 great cases, excellent discussion, excellent interaction from our attendees, honestly. Just before we conclude, I would like to ask, Dr. Sami, do you have any last input? Because we already exceeded the time by 10 minutes almost.
Thank you so much. Thank you so much. It was great that having Dr. Badriya with us. I hope that you like started with us since the starting for the scorpion.
There
Thank
is
you,
a lot
Dr.
to learn.
Bedri. I love hearing you.
Thank you for our presenters. Thank you for this great presentation and great cases. Thank you for all our attendees. And inshallah, shortly, like within 1 week, we'll try to send your CME certificate. And please join us for our next MENA Tox clinical round. It will be on November 11th. Please feel free, to contact me if you have any cases that you would like to share. My email is drafra.suwaidi, SUWAIDI, @gmail.com. And مع السلامة everyone till we meet next time.